My name is Dr. Karen Smith. I'm Director of Ethics Integration for Henry Ford Health, and I'm happy to welcome you to Ethics for Lunch. Usually about once a year, we like to focus on a difficult case that we've had and highlight how ethics is involved sometimes in difficult cases. Today, we're going to talk about a difficult case of a prisoner patient, and the issue is primarily the prisoner's autonomy. I'm very happy today to welcome my experts. We have Dr. Vivian Wu from otolaryngology and Kelly Bryce from behavioral health. They'll be our experts in going through this case. If you haven't done so already, please sign in to the cloud to get your CME credit. This number will be placed in the chat if you miss it, so just scroll back up and look for it in the chat as we go forward. You can sign into it anytime during our talk today and for 2 hours following our discussion. You can see that we have nothing relevant to disclose today. We're not getting paid for this. Moving on to our agenda. I'm going to have a brief case presentation, and then Dr. Wu will go over in more detail the medical facts of this case and an overview. Dr. Bryce will then talk about the psychological evaluation of this patient. And then at the end, there's quite a bit of ethics and law review, providing some clarification on patient rights. I'm going to start today with just a few facts that some of you might not have known. First of all, individuals who are incarcerated are especially vulnerable in that they are disproportionately affected by many chronic diseases such as hypertension, HIV, hepatitis C, serious mental illnesses, asthma, and other illnesses. And also, they hold a unique position in the U.S. healthcare landscape as if they are the only patients who have a constitutional right to medical care during the period of time that they're incarcerated. So consequently, the U.S. jails and prisons provide healthcare on a massive scale across our nation, especially as more and more persons are incarcerated. There's $8 billion was documented as 20% in 2015. I'm positive that that number has only gone up as healthcare costs continue to do. So keep that in mind when you talk about the care that we are providing to prisoners. The standard of care, and we'll talk about this towards the end from the Federal Bureau of Prisons, is called equivalent care, and that medical care that those who are incarcerated receive must be equivalent to what's able to be obtained outside of the prison environment. We'll see how this plays into this patient's care as we move forward. So just very briefly, a large view of this patient case. It involves a male patient who's in his 60s. He was a prison inmate. He had a history of having a stroke, AFib, hypertension, and a papillary thyroid carcinoma. During the admission that we're talking about is the difficult patient admission, the patient was wanting to refuse a feeding tube, which was considered potentially life-saving. Okay. Dr. Wu, would you like to talk more about the patient's course of illness?
Yes, I'd be happy to. So I really want to thank everyone for joining us today. This was a tough case for me just clinically, and to be honest, all of the, complications I guess that happened afterwards were not unexpected. But I will say the response and his response were quite unexpected. So certainly that's the reason why we are here. So I'll certainly go over the case itself and then what actually happened. Okay, so I first met him in November of 2019. He had noted some actually palpable neck masses low in his neck for several months, and a CT of the neck and chest, as well as an FNA of those, which is a final aspiration of those neck masses, were ordered. When I saw him, the patient was hoarse, and when I scoped him, I saw that he had a left vocal cord paralysis. And really, at this point, I didn't really know. What was going on in the neck. I mean, I could feel the neck masses, but what exactly were the details of the anatomy? Didn't really know that until I got the CAT scan. But the scope exam showed a left vocal cord paralysis, and he had also had a recent history of stroke. Next slide. So the CT scan was done, and actually you can see that the finding aspiration was done of the right thyroid. Remember, the left vocal cord was paralyzed, but his cancer was actually on the right side. And so for those of you who are not familiar with thyroid surgery, one of the biggest risks of the operation is that the nerve to the vocal cord might be injured. And in cancer situations, it's not often, but it is commonly the case where the nerve could certainly be invading, or excuse me, the cancer certainly could be invading into that nerve. And so again, I've got a left-sided paralysis from his stroke, and now I have a right-sided cancer where I could certainly take out, I could do it with the surgery, or the cancer could take it out of that nerve, which would innervate his vocal cords. So next slide, please. So the other issue, of course, was that he had had this recent stroke, and so I had had him go to University of Michigan, Dr. Zuranek, and I'm sorry to just kind of put his note in here, but I guess I just want to let you know that very thorough job that this neurologist did. This is 9 of like I think 15 points that he put on there. But again, regarding his thyroid surgery, is there an urgency to this? Does it have to be done immediately? Maybe if we can wait, then we should wait so that he could get some anticoagulation and recover from the surgery. And really, thyroid cancer does allow for that. And so we did. We waited the 6 months before sort of reassessing. And in the meantime, we did repeat scans because those scans that we had gotten earlier were from, I think there was a 9 month a difference in timing. And so it just showed the same sort of larger but same thyroid gland as well as some pulmonary nodules. Next slide. So unfortunately, we got the new scan, and December of 2020, he strokes again. And he has new left-sided weakness, and of course, still paralyzed of that left-sided vocal cord. So next slide. So again, I had him go see Dr. Zuranek at University of Michigan, and it just wanted to get his opinion again. And so, we are about 5 months since his second stroke. But at this point in time, it's probably worth it to start proceeding in around June is what we were thinking. And so, next slide. So in June of 2021, we went ahead and proceeded with this operation, a total thyroid, removing both sides of the thyroid. It's one thyroid, but both lobes of the thyroid. I did do a central neck dissection, and he also had disease of his lateral neck. So it was a pretty extensive operation. But really the issue was when we got into the case that cancer was invading into the nerve. There was no way to separate the nerve from the cancer. And so I knew I had to take the nerve during the operation, which means that he would have both a right and left-sided cord paralysis. And at that point, you can't really extubate a patient because his vocal cords are basically together and he couldn't breathe through it. So I had to perform a trach at the end of the case to bypass the vocal cords and allow him to breathe. And so that was the surgery. So then the hospital course, and so I guess in making that decision, and in this situation for anybody who has a bilateral vocal cord paralysis, which of course is devastating, but we do trachs with the expectation that down the road we can likely get that trach out. We need to probably do what's called a cordectomy, where you remove one of the vocal cords and allow sort of space for someone to breathe. But that, of course, means that the patient's voicing is a little bit worse. But again, in doing that trach, it's not a trach that we expect the patient to have forever. Um, Anyhow, post-op day 1, we did scope from the nose to look at the vocal cords. Of course, there was no cord motion, and the trach was in place. Communicates with the neck wound, which is expected in this situation. He was restarted on his Xarelto on day 2. And then on day 3 or 4 there, he had arm weakness. And so, of course, the concern was that he had potentially stroked again. And throughout this time, it wasn't clear that he was having swallowing difficulty. But when we got to the MRI on day 4 or 5 here, he really wasn't able to lay flat because he kept aspirating. There was a saliva just going down into his windpipe. And so we had our speech language pathologist perform a FEES in which you are testing the sensation of the glottis. And it was very clear that he was aspirating on swallows. And so next day, just increase in aspiration events, coughing a lot when he was drinking or eating anything. And so the recommendation, of course, was made to perform a G tube. And it was at this point in time that he declined the G tube and was really not interested in talking to me any further about anything. You know, I had gone to him to discuss, this is the plan for getting your trach tube out. We do need your G tube in there as we get you recovered. But he really, at this point, had kind of shut down with me and was not really interested in talking about anything further. MRI ultimately was negative for any stroke. And we did consult Dr. Smith's team at that time regarding his refusal of the G tube. And then finally on July 4th, he was discharged to the care of Duane Waters. So next slide. So sort of there's several, I think, points that come up here. You know, patient surgical treatment, I guess you could call it successful. We did get the cancer out, but in the meantime, there were complications. For example, of course, his nerve had to be taken and therefore he needed the trach to breathe. In placing the trach and having the nerve resected, that does lead to some swallowing difficulties. And so again, him having sort of chronic aspiration events down the road, that would certainly lead to probably a pneumonia. And so our G-tube recommendation really was to prevent pneumonias down the road, which could ultimately be the source of his demise. Overall, you know, good prognosis from the cancer perspective. We could certainly treat it. As I said, we could remove that trach by doing chordectomy. It's very possible he could have gotten his swallow back. But we would certainly need him to recover. I mean, this was again only about 10 days after a pretty big operation. But he at day 10 really wasn't interested in discussing any further anything that we could do for him. And so, you know, what were some of the issues with the patient? Certainly he could be depressed. You know, was his decision in an effort to end his life, you know, or just maybe try to get out of the prison situation he'd had before? Does that even matter? Could he even choose these sort of things by himself? And so I will hand this over to Karen to discuss further some of the ethical concerns. Yep.
Thanks. So ethics was initially consulted, and the reason was just stated as the patient refused the G tube. So there were a lot of ethical concerns that were kind of milling about. The concern would the patient die without nutrition or suffer pneumonia from chronic aspiration? Does beneficence demand that he go ahead and get this artificial feeding tube? Can prisoners even refuse life-saving treatments? People didn't really know that. Should the warden be notified? And was it really the warden's decision or was it the patient's decision? Should the family be notified? Does he have someone that could, you know, talk sense into him that he could continue to live if he made some adjustments to his quality of life, or that some of these things are temporary? All of those things are going on. Are prisoners granted the autonomy to make these decisions on their own, or do we need to include these other people? And really, does a patient truly understand what he's requesting? Does he have the capacity to make this decision? So if you've ever ordered an ethics consult, you know that one of the first things I always want to know is, does this patient have the capacity to make this decision himself? Does he maintain that decision-making capacity? So of course, the first thing I did was consult behavioral health. So I'm going to let Dr. Bryce talk about her the assessment that psychology and behavioral health did on this patient.
Yeah, thank you. So this evaluation was completed by Dr. Amy Williams, who at the time was the psychologist working with the ENT team. She is off on vacation today, so she is not able to present. So I'm filling in for her today. Karen, we can go to the next slide. So I have components of the capacity evaluation here and just wanted to talk a little bit about the conversation that Dr. Williams had with the patient and the determinations that she made regarding this patient's capacity. So Dr. Williams has a great deal of experience in working with ENT patients and completing these types of capacity evaluations. And so she did sit down with the patient for a long period of time, pencil and paper evaluation to get all the information to thoroughly answer the questions that are pertinent to a capacity evaluation. So the first component noted in the evaluation was patients' understanding of the nature of medical diagnosis and prognosis. So he was familiar with himself in his current location and his medical condition and could describe what was going on medically for him at the time. Some additional information that she included here is that he understands that he's aspirating when eating due to the nerve being sacrificed due to cancer surgery on his thyroid. So the next statement was, our next component here is patient's understanding of recommended care and medical treatment options offered. So the patient was able to adequately describe the treatment options. And it was found that he understands a recommendation for feeding tube due to aspiration surgery for thyroid cancer, understands that feeding tube would likely be permanent due to nerve sacrifice during the surgery, understands that without feeding tube, he would be at risk for aspiration, pneumonia, malnutrition, starvation, and death. Notes that feeding tube is not in line with his values and what he deems quality of life, and refuses to have the feeding tube, even if it means further morbidity and mortality. And so we can go to the next slide. Next component here is patient's understanding of each alternative recommended course of action and the likely risks and benefits. So it was determined that, yes, he did understand that, and he reported benefits of the tube to include safe feeding, appropriate nutrition, decreased risk of aspiration, pneumonia, and death, and risks to include aspiration, pneumonia, malnutrition, starvation, and death. Next component, patient's decision, treatment options accepted or refused. So the patient was able to express a rational choice that was consistent with their values and goals in refusing the tube. And it was found that he was able to make his choice without any coercive force, such as intimidation, psychotic or depressive symptoms that could impact their decision. He was able to give a rational explanation as to why he was refusing the treatment. And additional information regarding the patient's decision on treatment options being accepted or refused were reported to include notes that his quality of life at this point is not in line with his values or considered positive, that feeding tube, in addition to other medical comorbidities, does not add to his quality of life. He denied symptoms of depression, anxiety, suicidality, notes that he does not wish to die, but if my number is up, I'm okay with that. States that if his brother or his DPOA were with him today, his brother would agree with what he was saying and that they had discussed these things previously. Next slide. So also included in this evaluation was assessment of mood. So it was found that he did have some intermittent sadness, some low energy fatigue, disrupted sleep, which seemed to be related to his trach care. But otherwise denied symptoms of depression, suicide, homicidality, any plan or intent, denied higher baseline anxiety, panic attacks, OCD. He had some worries about his medical condition, particularly that he didn't want the trach either, which would be appropriate under the circumstance, and denies psychiatric history. So a cognitive assessment was completed as well, and it was found that despite his history of stroke, he was cognitively intact at the time. There wasn't significant substance use history. Social support assessment was completed, and it was found that he'd been in prison for 14 years. It'd be several years before he was eligible for parole. He had good support from his family, and his brother, as we noted already, was the DPOA. The family was aware of what was going on, but they haven't spoken with him directly. He thought there was likely a completed advance directive somewhere, but he didn't know where that was. So the determination was made that the patient exhibits full capacity and was able to make this decision. So the recommendations that Dr. Williams made were to consult with palliative medicine to have goals of care discussion, to contact the brother/prison to see if the advance directive could be located and provided for scanning to our hospital system. And then finally, ethics consultation service to provide guidance on prisoner refusal of treatment.
Thank you, Kelly. So a lot of times there's confusion regarding exactly what rights prisoners have. One of the roles of ethics is to help provide clarification about policies and rights. And I think that's one of the things that ethics was able to assist with here. As Kelly mentioned, this patient stated that he had an advance directive. And prisoners do have the right to designate a patient advocate just like every individual, and it generally follows the same laws that everybody else does. If you look at this form, and I apologize, it's not a very good form, and I actually had to use old-fashioned whiteout to white out the sections of that. Since I don't belong to the prison, I couldn't get a clean blank copy, but this is from the Michigan Department of Corrections. But it has the same thing. The patient is able to identify who they want to act as their patient advocate. They also are able to document a subsequent choice, right? So if their first choice is unavailable or passes away, they can designate a successor patient advocate. And then just like in the outside of incarceration environments, it needs to be witnessed by two people that aren't related to them. Now, you'll see I highlighted in red, there is one exception that where we could identify anybody we want to be our patient advocate, prisoners cannot identify another prisoner as their patient advocate unless that person is also verified as one of their family members. So that's a significant exception, and I have no idea how frequently that pertains, but it is a significant difference from anybody else completing an advance directive. And they do have this special form for patients who are also prisoners to utilize for this. And we have seen them come in. Ethics always looks for advance directives. This patient's advance directive was not screened into his chart, but as Kelly said, this patient had capacity, so he was able to not speak directly, but he was able to clarify his needs and wishes to us directly. So the U.S. Department of Justice, through their Federal Bureau of Prisons, states, again, as we mentioned when we started, the principle of equivalency for healthcare and treatments, and that prisoners are expected to be able to obtain the same level of treatment as those who are not incarcerated. Another special situation or exception is that if the patient is requesting a DNAR order or do not resuscitate for themselves, it has to be approved by the clinical director or acting clinical director of that prison institution. We'll see how that plays in. Further, when it comes to situations of serious illness and death, such as when we're talking goals of care, again, talking about DNAR, the inmate who's in a community hospital still receives regular medical services. The Bureau, though, retains their authority no matter where that patient is regarding movement of the inmate, visitors, and very few limited medical services because they act as like the insurance. So if things are considered experimental medical services, then we would need special approval to do that. But for most general medical services, they are authorized. The hospital then retains control for what we order for patients, the medications, lab tests, treatments, operations, and things like that. And generally, as long as the treatment's conducted by the hospital, there's really not any problems in providing general medical care. When it comes to serious illness or end-of-life care, the hospital is permitted to follow their established bylaws, or we call them policies, for seriously ill or dying inmates, such as initiating DNAR orders or discontinuing life support services when appropriate. Sometimes we do have prisoners who come in who are unrepresented, and oftentimes this happens where they don't identify any family, and we'll call the warden and they can't identify any family for the patient, and they have no one to make a decision, and they are actively dying. So we will utilize the ethics committee to do DNAR to prevent needless pain and suffering of someone at the end of their life by the ethics committee, having a unanimous evaluation with at least 3 members of the ethics committee. We can support physician judgment to change a code status of an unrepresented prisoner to DNAR. The prison system is kept informed of the treatment that the inmate's receiving, but really it's still up to the medical staff to determine what that appropriate medical treatment is. If we identify that someone is facing the end of their life, then we could notify the warden, but it has to go through the warden to notify immediate family members and to make any decision regarding end of life visitation. Now, oftentimes that is approved, but again, this is not our decision. It has to go through the warden. We do not contact the family. The warden is responsible for doing that. That was not appropriate in this case because our patient was stabilized and doing well and expected to return to his prison environment. But I think sometimes that's a point where people get confused about what we can do and what we can't do. Our go-to point is if we think someone is nearing the end of their life is to notify the warden so that they can make decisions regarding visitation. We talked about our patient and we had a capacity evaluation, and Dr. Bryce was able to tell us that our patient at that point in time did have capacity to give consent or withhold consent for medical procedures on his own. And this is directly from the Michigan Department of Corrections policy that prisoners are presumed, just like every other patient, presumed to be capable of providing their own informed consent. And if they can't, if they're incapable of providing informed consent, just like with the outside population, it goes first to a patient advocate, then it goes to a legal guardian if one is assigned. If one is not assigned, it goes through regular next of kin delineations. It's clarified for prisoners in the state of Michigan to their spouse, then their parent, then adult child or adult sibling. If we have a prisoner who is lacking in capacity, expected to survive, and does not have a next of kin or any identified persons that were listed above, then once again, we have to notify the warden or the prison administrator, and then they pursue guardianship. Where if it was a regular patient in our hospital, we might pursue guardianship to get a legal court-appointed guardian for patients without representatives. If that patient's a prisoner, we have to go back to the prison, and that falls underneath their authority to seek obtaining guardianship for those patients. Also similar to the regular population, if the patient's in a life-threatening situation, they may receive emergency medical treatment under medical necessity, even if they're incapable of providing consent. Again, if something else is going on and they are needing special help or needing to have an ongoing guardian, we have to return again to the prison authority and provide them that information. And we need to do that as soon as we determine that that patient's capacity is going to be an issue. Special concerns when needing to address a prisoner-patient surrogate. So if we think our patient has lost capacity and we do need to talk to their patient advocate, in this patient situation, it would have been his brother or other family or next of kin, we can only do that at the actual time of need. So if our prisoner patient had come in and we did have a copy of his advance directive, after we had our capacity evaluation, we knew at that point in time we still could deal directly with our patient, which happens to further that patient's autonomy and his ability to make decisions for himself, and that's fine. Had he been found to lack capacity, then even if we had information on the advance directive, before we could actually contact that patient advocate, we would have to notify the Michigan Department of Corrections in order to speak with that surrogate at time of actual need. So while patients are prisoners, they've lost their rights of contact with society, including their family and their surrogates. So their freedom is significantly retained, even though they retain all of their rights for appropriate healthcare services. So once that patient loses his decision-making capacity, then we have to notify the warden. This furthers the patient's autonomy and being able to make those important decisions for themselves. It also allows us to be compliant with Department of Corrections regulations regarding prisoner contact with outside persons, and following those laws and regulations mandate that we contact the warden prior to contacting anyone in that patient's family or any advocates. So our Jackson Hospital has their prisoner unit, and they probably have the most contact with prisoners. There's currently a Tier 2 policy, which you could see in our hospital policy portal, for informed consent from Michigan Department of Correction prisoners. And it goes through a lot of the things that we just did on these previous slides of how to do this. Mostly this is for patients when they're unable to provide informed consent. And the ethics policy subcommittee is going to be looking at taking this Tier 2 policy and adapting it so that there'll be clarification for everyone across our system on what to do when we contact these prisoners. Because so very often we have concerns or questions when these things come up. Not only are there questions such as those that we addressed about capacity and can they make those decisions, oftentimes there's just a lot of concerns when dealing with the patient prisoner population. There is a study that came out many years ago, but I think it's interesting that the primary findings from this study are those things that I think we face every day in caring for our prisoner patients. And the article is about how we actually deliver that equivalence of care for prisoners and talking about the prisoners' experiences. And several of these things we saw was security was really overriding the healthcare needs or experiences, and having those guards in patient rooms. That oftentimes having the guards or security there all the time creates public humiliation or fear from nursing staff or others, and going in to take care of their patient and just having common communication. Difficulties in relating to the prison officer's role in medical consultations. Oftentimes people have asked me, can I just talk with my patient alone? Can we have a consultation? And it is okay to ask the guards to step outside of the room. Prisoners who have autonomy to make their own decision also have a right to privacy and consultation with their physician. If they are in a private room, which they almost always are, the guards are still doing their jobs if they're standing outside of the room to allow you some privacy and consultation, or evaluating, or doing dressing changes, or any other private care of a patient. It's certainly fine to ask them would they mind just stepping outside. Dr. Wu did not specify, but in our discussion earlier, she said that oftentimes there's delay in access due to the prison practices in getting transportation arranged for consultations and follow-up appointments and things like that. So oftentimes prisoners' care is delayed due to those things. And so therefore the patient's autonomy sometimes is restricted in management of their own health care and getting their health care needs met. So there are a lot of problems, and I think as I started off this talk with mentioning that they are especially vulnerable population in many ways is important just to consider in how we're providing them with the respect due to everyone that we're providing health care to when they're in our environment. So let's go back to some of those earlier questions we had about this patient. Does this patient truly understand what he's requesting in refusing that G-tube, and does he have capacity? Dr. Bryce was able to go over the behavioral health evaluation that said the patient did have capacity to understand that he might be hastening his death by refusing the feeding tube, increasing his risk of aspiration, and the pneumonia. The patient was still interested in requesting hospice care. As you recall, changing code status to DNAR and hospice care are things that have to be approved by the warden. Does beneficence demand that he's artificially fed? So this would only occur if we were unable to obtain the wishes of the patient, and if it would be proportionately beneficial to do so. So in this case, the patient did have the right to refuse any and all life-prolonging treatments. Who gets decision-making authority? Are prisoners granted autonomy? Hopefully now we all can understand that although prisoners' liberty rights are denied, prisoners with capacity still retain their autonomy or their right to make their own medical decisions, and to name a patient advocate or surrogate or next of kin if they lack capacity. Should the family be notified? Can they visit to talk sense into this patient? Actually, no, not in this case. Only in cases where it's approved by the warden, and generally that's at the end of life. So it wasn't appropriate in this case, although it was recommended both by behavioral health and also by ethics, since we did not have a copy of that patient's advance directive, that he complete a new advance directive if it was not at his prison, to name his brother, because he was consistent that that is the person he wanted to make his healthcare decisions when he was unable, and that he had had discussions with his brother prior to his incapacity or his medical illness that limited his speech. And so he felt his brother did know his desires, and we wanted to make sure that that was done, and he needed to do so before his health were to decline further. Should the warden be notified? Per policy, the warden will be updated at discharge of the patient's concerns and the patient's request for hospice care. So what happened in this case? The patient was transferred back to the prison, as you saw, 2 days after ethics was consulted. Our role in this patient's care was very small and short. It was just at the end of his stay here. Importantly, we consulted behavioral health to do that capacity assessment, and really they had a critical role in explaining to the patient why he needed to share with us more his thinking and be transparent about his wishes. The patient did petition for hospice care to be granted by the warden. He did not return to our hospital again, and he has since passed away, to our knowledge, without additional life prolonging measures. So now, if you have questions, I am asking that you type them into the chat, and we will get the appropriate person to answer them.
We do have one in the chat now, Karen.
Okay.
It says, is there ever a time when the designated surrogate decision maker for a prisoner would not be allowed to be part of the care or be involved?
No, I would think that they do have that right, as you've seen, but it has to go via the warden granting permission to talk to them. And they do that in various different ways. If it's end of life and they're needing to make that decision, then the warden may allow a visitation, and then it has to follow whatever guidelines and rules that the warden puts on it. And those could vary depending on the status of the prisoner, to have conversation with them. So it may be visitation, it may be a phone call, it may be a phone call on, them calling us rather than us calling them, or on special numbers. The other case where that might not happen will be if we're unable to reach that surrogate, which sometimes happens with any advance directive. People do not keep them updated, so we may not have a correct number, and the prison may not have a correct number, so we may be unable to reach them.
There's another question here. At what point do medical treatments or interventions such as trachs and pegs interfere with the patient's ability to return to the prison? And how do we take that into account?
Dr. Wu, were there any concerns about the patient returning to the prison with his trach?
No, I mean, I think that they are able to handle the trach and peg situation, so that wasn't an issue for discharge.
Yeah, we've had that several times. They're able to care for a lot of things there. I think we have had prisoners in the past transferred to LTACs if they had significant care needs that were unable to be done. But then that was a more complicated patient and a process that had to go through the warden again. The Bureau of Prisons is actually their payee or their insurer acting type.
Here's another question. May a provider use the verbal designation of medical decision maker document in EPIC with a prisoner?
Heidi, I'm not surprised that you asked that question, because I have been thinking that myself. Once again, I would think in that situation, verbal designation of surrogate decision maker is a Henry Ford Hospital policy. It's not something that is formally allowed either by the Federal Bureau of Prisons or Michigan correctional authority. So in that case, if a patient was wanting to name whom he wanted as his surrogate, I would definitely think that we would need to contact the warden of the prison directly and share with them the prisoner's request and our belief that that patient would subsequently be losing capacity and not have the ability to complete an advanced directive at that time. So that would be a special situation that we would have to address with the warden. And I think if we move forward on a tier 1 policy across our system, hopefully that would be something we could get clarification on in advance. That's a great question, though. Any other questions? Now's your time to type them into the text. Also a time to remind you that the CME code for today's talk is 52855. So if you've yet to enter your cloud CME, the code for today is 52855.
Another question here, Karen. Does any of this differ for NGRI patients?
What is NGRI?
It's the not guilty by reason of insanity patients.
Oh, thank you. Well, I would say, and Kelly, you can help me, if they were deemed insane, capacity is determined at every point. We would definitely need a new capacity evaluation, right?
Yeah, per each procedure, I guess. I'm not familiar with the legal system enough to answer that question.
Yeah, that's a really interesting question. I would say the capacity is a moment by moment determination and it's question specific. So, you know, depending on how long they have been incarcerated and the treatment that they've received there, that could have changed. It could not have changed. I would say it would be based upon their capacity because we only ever use surrogates when we believe the patient doesn't have the ability unless they have a legal court-appointed guardian, which has taken away their right for independent decision-making, and then we would need to confer with that person. That's an interesting question that I hope doesn't come up, but probably will tomorrow now that somebody's brought it up here. And we'll have to figure that out. Interesting question, though, one that I hadn't thought of.
Okay, next question. Who with medical knowledge backs up the warden's decision to approve or deny care to make sure that a prisoner is treated fairly?
They do have medical directors at the prison, but I think that most of the time, due to the mandate for equivalency in medical care, that prisoners are granted that. The only exception would be something if it is like considered experimental treatment, something that a private insurer may not approve or may approve, then it might have to go to a higher level. But generally the wardens do follow, again, hospital institutions and medical institutions have the right to direct the medical care for the benefit of the patient, and the wardens then do generally comply and follow that. Regarding end-of-life care, I think that they have mostly, if we say the patient is nearing the end of their life, it's appropriate for family to have visitation, then we share that with them and they make those decisions. But I think they generally are believing what our medical providers say about, is it a serious end-of-life situation? And is it appropriate to request those end-of-life visits?
Next question. If a patient has a medical directive prior to incarceration, do they still need one through the prison system?
Ooh. The prison advanced directives follow the same state requirements. Again, they name their patient advocate and they name a backup, and it's still witnessed by two people who are not related to them and not involved in their health care. So I would foresee and believe that it would be the same as long as they do not name another prisoner unless that prisoner is related to them. Because their guidelines, if you read that document that I showed early on, are pretty clear and pretty simple. So as long as it met the guidelines that are in the MDOC guidelines, I would think that it would be fine, although probably many of them, just like in the general public, do not have one. But this form really mirrors the requirements for any valid advance directive in the state of Michigan, with the one exception.
Is the cost of any care or procedure an issue?
I can try and answer some of this. I would say that it depends on what the care or procedure is. We see a lot of the head and neck cancer patients, and we try to get everyone in for what's called a pre-treatment evaluation. We have speech language pathology see them to assess their speech and swallow. We have our psych-onc see them to assess their capacity, etc. We have a nutritionist see them, and the prisoners frequently are unable to participate in that pre-treatment set of appointments. Procedure-wise, though, I think that as same answer to the fact of medical knowledge backing up the warden's decision, I think that ultimately they rely on us to say, okay, at least this procedure needs to be done. But for other care, for example, the ones I gave, those are ones that we certainly have had pushback for requesting, and we really don't get our patients in for those at all.
Yeah. And that was highlighted in that article that I referenced to, that sometimes that transportation and arrangement of things is difficult or can take time. Anything else, Kelly, or is that the end of our questions?
Nope, there's one more here. Says incarcerated persons have a type of Michigan Medicaid and have case management that closely follows patients. So more of a
Comment, yeah.
yeah.
I think our go-to person's name is Rebecca or something. I seem to recall that one name coming up a lot. So I want to thank all of you for tuning in during your lunch hour today. I want to especially thank my guest presenters, Dr. Wu and Dr. Bryce, for sharing your expertise with us. I hope that everyone enjoyed this presentation and maybe learned a couple of things about taking care of our prisoner patients. And I look forward to seeing you again in August for our next Ethics for Lunch. Thank you all and have a great day.